Okay, are we good to go, Hussein?
Yes, sir, we are.
Okay, I would like to welcome everyone to October 22nd Grand Rounds. We have some great cases tonight. I would like to, as always, thank my good friend, Dr. Hussein Tarek, prosthodontist and clinical director at IATX Pros. He has been working feverishly all day today. We have 10 very, very good cases that he told me are rather complex, so that's very good. So again, thank you, Hussein. I would also like to welcome Dr. Robinette, our clinical director. He will be online. If you have any questions, you can put any of your questions into the chat, and he will answer those during my short little lecture and the case presentation. As always, I like to give a little lecture on a clinical pearl. And this is going to be a short one tonight because we do have some rather complex cases, but it's a very important one. And Dr. Hussein and I were talking this morning, and we still see so many of these cases that come in for the maxillary posterior where the scan limits are not ideal. So what do I mean by that? Well, in this particular case, there is a large mucus retention cyst, pseudocyst in the right sinus. It's rather large enough that we're going to have to refer it to an ENT surgeon. However, the scan limits were not set high enough. And what's going to end up happening is you refer to the NT, they're going to have to rescan the patient. Therefore, our goal is always to be able to see the ostium in cases where we're going to enter the sinus proper. Now, what are those procedures? Again, to review, SA2 is where we bump up the sinus with no bone grafting. SA3 is where we're going to place an implant and graft. And then SA4 is a dedicated lateral wall sinus graft with delayed implant placement. Our goal, though, anytime we enter into the sinus, we must determine the patency of the maxillary ostium. Therefore, when we're taking our scan, you have to be very, very careful that your staff understands the limits of the scan. Some offices, their basic protocol is to go to the anterior nasal spine. Others I see go to the mid sinus. Others to the infraorbital rib. So what we're going to do is talk today about where those limits are so you can communicate with your staff. So when you do have a case where you're going to enter the sinus proper, you're going to have the CBCT scan taken high enough. First of all, anytime we are doing an SA1 technique, an SA1 is where the implant is below the sinus. We're not going to enter into the sinus proper. With an SA1, a mid-sinus CBCT in the superior limit is fine. However, when we're looking at an SA2, SA3, or an SA4, we have to go much higher. Now, why is that? Because we have to determine and verify before we enter into the sinus that the maxillary ostium is patent. As we know, that is the main drainage avenue of the maxillary sinus. And if it is not patent, then our implant and or bone graft is going to get infected or failure. Therefore, the term that we want to use is patency. Patency means it is open and it is unobstructed, as you can see in these images right here. Now, when it is patent, as you can see on the right side of your screen, any mucus, any allergens, any serous accumulation in the sinus will go against gravity. You know, that is our normal mucociliary clearance through that opening, which is called the ostium. That then transverses through a tunnel area called the infundibulum into the hiatus semilunaris, through into the middle meatus, and then down into the nasopharynx. If we do not have that patent, then what ends up happening, such as on this left side or the center of your screen, that is what is called non-patent. There is no ostium opening. Therefore, that mucus is going to sit in this, or any irritants in the sinus. It's going to stop the mucociliary reaction, and then we're going to end up with infection and or failure of our implant and graft. Therefore, it is very, very important that before you go into the sinus, you verify that it is patent. However, remember, we're going to look at sequential images. So on this image on the left, 101, you can see it is non-patent. However, we go 1 millimeter away, 102, and you can see it is patent. And then 103, it's even more patent. Therefore, look at sequential images and verify the patency of the maxillary ostium. Now, when is that significant? It's going to be an SA2, which is on the left where we're going to bump up the membrane. SA3 is when we're going to do a crestal graft and an implant. SA3 can also be a lateral wall and implant placement. And then in the center of your screen is an SA4. For all those, we're going to verify that we do have that ostium that is patent, and that is going to be ideal. And medical legally, we need to verify that. So to answer the question, where should you be telling your staff to take the upper limits? The minimum is the infraorbital rim. It should be superior to the infraorbital rim, slightly superior, and the maxillary occlusal table on the inferior. So those should be your limits. If you do take those scanning limits here, we will, at a minimum, see the maxillary ostium. So you can see in this image where we are just above the infraorbital rim, we can see the ostium. We can actually see up into the ethmoid sinus. And usually, as you remember, when we do end up with a rhinosinusitis in the maxillary sinus, we then a lot of times will block off that ostium and the osteomeatal complex, further blocking the ethmoid sinus and possibly the frontal sinus. So again, you want to go just superior to the infraorbital rim and then the occlusal plane. Most midfield view CBCT units will put you in that position, no problem. Therefore, if we do have to send this to an ENT, the ENT can easily verify it and treat the patient. If not, what happens is the ENT will say they have to take another scan, and now the patient is coming back and could possibly be upset that they have to be rescanned. So do it right the first time, and that will alleviate any further problems. Okay, with that being said, I am stopping my sharing, and Dr. Hussein can take over. And let's do the first case. Any
Yeah.
questions on that little lecture? Dr. Robinette is on, and you can add any questions, and he'll get right back to you. Who's our first doc?
First, Dr. Resnik is Dr. Mangiafico. Dr. Mangiafico, would you mind please unmuting yourself and presenting your case to Dr. Resnik?
Hi, Doc.
Uh,
How are you?
Good. How are you?
Good, good. What do you have for us tonight?
So it's like a little bit more of a complicated case. She wants basically a tooth without having a partial
Okay,
number 5 area. She is 78, I believe. I don't have it in front of me, so I'm kind of just guessing on the age. But the bigger problems were she's on Fosamax for the last 5 years since 2020.
okay,
She takes that weekly. She's
okay.
also on lisinopril. I believe it's a beta blocker.
Yes.
And I think that's it. That
Okay.
I know I
So
sent.
so right off the bat, Doc, just for everyone on the webinar, since she has been on Fosmex, since she has been on it for over 3 years, that is a relative contraindication. Uh, this will not result in an absolute contraindication, but you will need to get a medical clearance. So I
Okay.
would use our medical clearance form. Secondly, I don't know if you've seen the new consent form, but I have a new consent form for bisphosphonates. I also have one for monoclonal antibodies it's a little bit more detailed. I would highly recommend you use that just again because there is a increased chance of osteonecrosis because of the 5-year history of Fosamax. The why that has changed a little bit is because the half-life of Fosamax is now basically infinite. So it's
Right.
it builds up in the bone and it does cause us some problems. But with that being said, you want to place one implant in number 5. Okay. Dr. Hussein, did you try an implant in here?
Yes, sir. I did add an implant at the side of number 5. I'm using a 4.3 by 10 millimeter implant over here, Dr. Resnik, planting this implant within the grafted bone and 2 millimeters into the maxillary sinus on the distal aspect of my implant over here, sir. Clear away from the laminate dura. What's your thoughts, Dr. Resnik?
Okay. Doc, did you say this is a female or a male?
Female.
Female. Yeah. Okay. So, the bone density is not ideal. So your D3, D4 bone density there. Is this a grafted site by chance?
Yes.
Oh, it is. Okay. So here's the deal on this. But put the implant back in.
Here you go, sir.
So to do an SA2 on this, I think would be, we're just asking for problems. There's really no reason to go into the sinus there. If you use the SA4 technique, where you're going to under prep by approximately 2 drills, I think you'll osteodensify it. And let's change that to an 8 millimeter length. Okay.
Here we go, Professor.
Perfect. This way you don't go into the sinus, Doc. There's no
Yeah.
reason to cause a potential issue. You stay below the sinus. Those 2 millimeters are of no value. If this was really, really poor bone, I would say possibly, but I think you do have some cortical bone there, so you'll have good primary stability. What he's doing is a 360 around it, Doc, so you have good bone all the way around. Your graft looks good. I would go, what is this, a 4.3 by 8? I think
Yes, sir.
you're good with that, Doc.
Okay.
That's a good case. Could I ask you one thing though? What's opposing on this?
It's not a good looking molar.
Okay. So is there any reason that you're only replacing to the bicuspid? No
'Cause that-
molars?
Yeah, just because the molar didn't look fantastic under it. I do believe there's a premolar under it, and the molar right behind the opposing didn't look great. So I felt like she might be losing that soon. And I do
Okay.
believe her inferior alveolar nerve is really close. It's
Really
like
close.
yeah,
So basically you're she's gonna have a bicuspid occlusion.
yes.
Okay. Okay, good. Good.
And my only question, I know we're gonna do the medical clearance, but is there a drug holiday?
No.
That's what you're saying, right?
No.
Okay.
So if the physician wants to do a drug holiday, I would downplay that. You don't need a drug
Yeah.
holiday with it. Yeah. No.
I got you.
So they're gonna rubber stamp, they're gonna just stamp it, no problem. Good to go. I'm just saying that medical legally, I would
Okay.
feel better if you have a clearance and you have that patient sign the consent.
So I just have a question because I have
Yes.
sent medical clearances, and they sometimes just kind of send stuff back and they're looking at me like, what do you mean? Like, what are you talking about? You're the doctor. So it's just kind of weird.
Okay, so you have our clearance form, right?
Yes. So just use that.
So write a cover page and
Okay.
basically state that this patient's been on Fosamax for 5 years, and you were just inquiring if there are any contraindications to dental implant placement because of the long-term history of oral bisphosphonates. And
Okay.
leave it at that. Yeah.
Okay.
No drug holiday, nothing like that.
Okay.
I don't think they would care if they did do a drug holiday, but it's certainly it wouldn't do anything because the patient has so much of this built up in their system, it doesn't matter.
I agree.
Yeah.
Okay.
Okay.
Perfect. Thank you so much.
Okay. Good
I
luck,
appreciate
Doc.
your time.
Okay.
Thank you. Bye.
Okay. Dr. Hussein, who's up?
Next is Dr. Resnik.
Okay. Hi, Doc. How are you?
Yes, how are you, doctor?
Good, good. What do you have for us tonight?
Yes, I have a 37 years old patient, female, healthy. Let Dr. Hussein put on the
I'm
CBCT.
loading it right now, sir.
Okay, thank you.
Yeah, it'll just take a second. Any medical issues?
No, she's
Okay.
healthy. So she
Okay.
have a missing number 30 and a two cuspid impaction heavily impacted.
Okay.
Number
So
6.
she has some primary cuspids, permanent
She still has
cuspids
the
are,
primary teeth prolonged there, hanging in there.
okay. And then she has impacted permanent
Yes.
cuspids. Okay.
And she doesn't want to go through auto treatment for these two.
Okay.
You know,
Which I agree, they would probably never come in. So you're looking at, were you thinking of immediate placement on this, Doc?
My question is if I need a bone graft on that buccal plate there for both sides, because it looked like it.
Okay. Well, I'll tell you what, let's do this. Dr. Hussein, did you work this up?
Yes, sir. I did add a 3-5 implant at the sites of number 6 and number 11. I'm going to start by presenting Dr. Resnik the site of number 6. So I'm using a 3-5 by 10 millimeter long implant at the site of number 6, sir. Right
Okay.
now, I'm covered with that thick cortical bone coverage over here, yep, to the facial. I'm intentionally exposing the first or the collar of my implant to the pathal aspect over here, Dr. Resnik.
Okay.
As
Okay,
I
Doc.
scroll, go ahead,
Oh,
sir.
go ahead. Scroll run.
I was going to mention, Dr. Resnick, that I'm avoiding engaging that impacted canine over here with the apex of my fixture
Oh,
by
nice.
tilting.
Okay. And that's a 3-5 by 8, right?
It's a 10 millimeter. That's a 3-5 by 8. Yes, sir.
Okay. Okay. So, Doc, I think this will work. You can probably do this immediate. The reason is once you take, are those primary teeth mobile?
Yes. No,
Okay.
very little. Yeah, very little.
How about mobile? Do they move?
Yes, a little bit.
Okay. So they'll be rather easy to get out. You'll have a plenty of lingual bone there.
Yeah.
He has a nice position. I would probably do this guided, Doc, because it'll be a lot easier. You don't have
Yes.
to do it fully guided, but at least either a pilot or a universal guide.
Okay.
And I think this one is fine. You can take some of the bone from your osteotomy and pack around that lingual, and I think you'll be fine.
Okay.
There'll be plenty of bone on the buccal. You probably don't even have to graft the buccal, Doc.
Oh, okay.
Yeah,
Okay.
I think you'll be good. Where he has it is like perfect.
Okay. Great. Great.
So let's go ahead and look at number 11.
Number 11, sir, is a 3-5 by 10 millimeter long implant. And Dr. Resnick, apologies about this, but there's a glitch with the software. In fact, number 6 is a 3-5 by 10 as well. It's not an 8 millimeter long implant, sir.
Okay, so they're both 10s.
Yes, sir. So for number
Okay.
11, it's a 3-5 by 10, sir. I did apply the same kind of relationship over here, exposing the collar of my implant as well. Good bone coverage to the facial aspect, Dr. Resnick. And as I scroll around this implant, we even got more space away from that impacted canine, and we're clear away from the laminatures of the adjacent teeth, Professor.
Okay. Doc, this one's a home run also. So I would do both of these. It would be a 2 supported guide, and I think you would be in good shape. You could do these immediate, no problem.
I'm sorry, but on the lingual there is an implant exposed on the lingual. What?
Yeah, so I would still graft it like on the other side.
Okay. Okay.
Yeah.
Great.
So if you, and Hussein, you know what? Just move the superior 1 click. There you go. I like that better. Okay. That'll even
Yes,
be
sir.
better. And you can always do screw or cement retained on these too if you have to. Now, Doc, one thing about this is bilateral canine implants. What I want you to do is when you build the crowns for this, you're going to tell the lab to do an immediate disclusion, a very short disclusion, meaning these implants are going to be basically ankylosed to the bone where the teeth have periodontal ligament. Therefore, you don't want these implants being too stressed when you disclude off of these cuspids. So what you want to do is a short disclusion, just enough so that you disclude or separate the posterior teeth.
Okay. I
Does
got
that
you.
make sense?
Yes. Yes. Definitely.
Okay, perfect.
Thank
So
you.
let's go down and look at number 30. Is that what you said? 30 also?
Yes. 30.
Yes,
Okay.
sir.
Okay. And did you work this one up, Hussein?
I did add an implant at the site of number 30, Dr. Resnik. If I'm correct, I'm using a 5.0 by 10 millimeter long implant at the site of number 30, and I'll be confirming this for you, Professor, once the treatment plan loads for us.
Okay, good. So, well, let's see what this looks like.
Oh, perfect. Oh, it's actually a 4.3 by 10 millimeter long implant, Dr. Resnick. And here is the position buccolingually, Professor. Perfectly clear away from the mandibular canal, sir. We're clear away from the laminators of the adjacent teeth. But one thing worth mentioning, Dr. Resnick, is that there is a periapical pathology related to the adjacent tooth number 29, Professor.
Wow. Okay. So,
Mm,
Doc,
yeah.
and that's 2.2, that pathology.
Yes,
So,
sir.
Doc, this one poses a little issue. Okay.
Oh.
So, that's a pretty significant pathology on that bicuspid. So that needs to be eradicated. So you're going to endodontically treat that.
Okay, yes.
So what you don't want to do is place the implant until that infection is cleared up. The
Yes.
reason is, Doc, even though you have 2 millimeters from where that infection is, the pH of that infection is approximately 6. So it's more acidic. The bone, ideally for bone to remodel or regenerate, needs to be between 7.2 to 7.4. Therefore, if you place that implant, the pH of that area, probably all the way up to that implant, is a little bit lower, and
Lower
it's
the,
just too risky. So here's what I would do. Phase 1, Doc, do an endo on it.
yes.
I would wait probably about 6 weeks, then go
Yes.
ahead and place that implant.
Okay, great.
Okay.
Yeah.
And another little tip, Doc, Dr. Hussein, you see those little blue lines there?
Right.
Okay, do some guide planes, and then you'll have one path of insertion when you put the crown in.
Okay, great. Beautiful.
Okay.
Thank you.
So just do the root canal first.
Yeah, just one quick question. I didn't put
Yes.
up there on number 19. That's a lesion on the distal there. Actually, patient had a lesion 3 or 4 years ago. It's much bigger than that, about two side, double the size of the distal canal right now. But right now, the patient has been asymptomatic, and there's still a
Yeah.
little small error there.
Yeah. So, Doc, what I would do is do a 360 on this.
You got it, Professor.
Okay. It doesn't perforate the plate. Doc, I would get that out of there. The reason is that is probably expanding. As it's expanding, it is compromising that bone. Therefore, the sooner you take it out, the better. Right now, you can take it out and debride that area very, very easily.
Mm.
If you let this go anymore, that could go all the way down into the canal, and you don't want to deal with that. So I would take that out, Doc, debride it real good, decorticate it, and then graft it.
Oh, okay.
Okay.
So this tooth after endo treatment is not healing up, even though the apical radiolucent C that's decreased in size, but much better as compared to the original.
Oh wait, I thought you said it increased.
No. It's decreased in size. Now it's half of the size it was before. Right?
Oh, okay. I misunderstood. I thought you
Sorry, I
said,
didn't. Yeah, I'm sorry.
okay. Then don't do what I said and just
Okay.
watch it.
Okay.
Yes.
Yeah, that's what I
Yes.
planned. Yes.
And what I would do when you ever take a scan, always keep watching it. And you can actually measure that lesion, and you'll be like, go to the pre-op scan, measure it, and then go to this one.
Yeah.
So
Okay.
if it's decreasing in size, then
Yeah.
it's fine. It's fine.
Yeah.
Okay. I
Okay.
misunderstood. Sorry about that.
Thank you. Thank
Okay.
you.
Have a good day, Doc.
Yeah. Thank you. You too.
Okay. Okay,
Next case,
Dr.
Professor.
Hussein, who do we have?
Dr. D. Bartola.
Dr. Wayne, how are you, buddy? Is Wayne on?
He is on. Yes, sir.
Okay. Dr. Di
Um,
Bartola?
I'm gonna check just gonna look for him really quick, Professor, but he was on earlier. Okay, would you mind if I go to the next case, Dr.
Yeah,
Resnick?
let's
And
just
if
go
you
to the
don't,
next one. Okay.
perfect. So for the next case, Professor, we've got Dr. Jared Lee. Dr. Lee, would you mind unmuting yourself and presenting your case to Dr. Resnick, please?
Yeah,
Okay,
give me.
Doc, how are you?
I'm doing good. This is let me grab him. This is his associate, Dr. Samby. He's just in the next room. Just give me like 20 seconds here.
Okay, no problem.
And meanwhile, Professor, I'm loading the treatment plan, or maybe not the treatment plan, but the patient's CBCT for your review, sir.
Okay. So this, I saw you had multiple scans there.
Yes, sir. So to give you some history, Dr. Resnick, the first CBCT or the CBCT I'm presenting right now was acquired back at December 2024, where the patient presented after placing that implant with some sort of paresthesia, if I read the notes that Dr. Lee left us. So what happened after this appointment is that Dr. Lee or his associate took out the implant sometime in January, grafted the site, left it to heal, and added one more time or reattempted implanting that implant for a second time later 2025, sir. I've got all the sequence of the CBCTs ready to be
Okay.
presented by Dr. Lee
So,
once he is.
is Dr. Lee on?
Yeah, I'm right here.
Hi, Doc, how are you?
Hey,
So,
good.
Dr. Hussein just gave me a good history here. So he said you placed an implant a couple years ago, which is the scan right here.
Yeah,
So,
so fully guided.
okay,
And we took the post-op CBCT. So I have like a before where we planned it. I have an after we placed it. Everything looked good. And then she came in a couple days later saying, "Hey, something feels really funny in my jaw." And we took another one. Everything looked the same.
okay,
But then we started having some symptoms, and around the apical portion of that implant, we started getting radiolucencies, and it started to get bigger until it started to put pressure on that nerve, and that's where we
so,
started to get the paresthesia.
can you describe the nerve impairment? What type of impairment was it?
So the lower was numbness. So it started out with a pain on the buccal, and
Okay,
then as time progressed, it turned into an overall numbness on the bottom, but then the pain was on the upper. So on the maxillary branch of the trigeminals where she was feeling it.
okay. So let me just go back so I understand this. So you placed an implant. The patient postoperatively started exhibiting signs of paresthesia.
Well, initially it was just pain. So she initially started having discomfort. It was very
Okay.
low grade, and
So,
then it gradually got worse as the swelling got worse around the implant.
okay. So you removed the implant, and what happened to the symptoms?
So I removed the implant. I did not place bone graft because on the CBCT, it looked like the swelling got down into the canal or down
Okay.
into where the IA nerve is at. So we didn't touch it. We just took out the implant, and they quickly started to resolve. So I waited. I believe it was about a month. Um, we took another X-ray on it. I could see the bone starting to reform down on that area so that I had a buffer between the IA nerve and the defect from the implant. So I
Okay.
went back in there, cleaned out any type of healing tissue in that, re-bone grafted that area once I had that
That
area.
buffer. Okay.
And then at that point, the bone integrated, everything was good, the no pain, no numbness, everything returned to normal. Now, a follow up on this because since I submitted all these, so we did go back in, we planned it, we made sure there was 3 millimeters of space between the nerve, the implant. We replaced it. Everything was perfect. We went 1 week, no symptoms, no nothing, no pain. And then right after that, she came in again and she's like, something feels funny again. We took a CBCT and there was a slight darkness around the apices of the implant again. We waited 5 days, took another one, and it was significantly bigger. So she's actually coming in tomorrow and I'm going to take out that implant again. And I don't know what's causing it because each time the placement seems like it's
Yeah.
perfect.
So the only issue here that I see is that implant's approximately 1 millimeter from the canal.
On
And
that first one.
yeah, so if you remember, our safety zone's always 2. The reason is, Doc, to put an implant in on this particular implant. What type of implant is this, by the way?
I believe that is Nobel active.
Okay.
Um,
So, you know what the Y dimension is? So everyone
Yes.
so the Y dimension means that, let's say that's a 10 millimeter implant. When you put a 10 millimeter implant in, you have to drill more than 10 millimeters, usually 11, possibly 11 and a half millimeters. Always remember that. That's why you never want to be less than 2 millimeters from the nerve.
Okay.
So if you're 2 millimeters, even with the Y dimension, you'll never enter the actual canal proper. Now, usually the superior aspect, what I believe probably happened, Doc,
Mhm.
is that you drilled this, you probably got into the top part of the intraalveolar canal, and the intraalveolar artery and veins are on top. The nerve fascicles are below. You probably ended up severing one of the blood vessels and got a little hematoma there. And usually, when you get symptomatic like that post-operatively, it's the result of a hematoma. So the hematoma bleeds, causes pressure, also with the inflammation, you put all that together, the patient ends up with discomfort. And you said on the buckle, so that kind of sounds what it is. The
Can we
only,
pull up the most recent CBCT of the second implant
yeah,
that was placed?
okay, why don't you do that? The
Here we go,
the
Professor.
only concerning thing that I have, Doc, is the
Yeah.
patient started getting nerve impairment in the maxilla. So V2 and V3 are completely independent. However, when you ever sometimes you'll get a trigger and for trigeminal neuralgia. And what happens is back in the trigeminal ganglion, you'll actually get irritation or inflammation, and it will affect one of the other branches. So anything that you did down here should not directly affect the V1, V2, V3, but you could have an indirect involvement. So
Okay.
here, go ahead, scroll through the, let me
So
see
this
this
is the
again.
one we'll be taking out tomorrow.
Yeah. Okay. I would check, Doc. You might have something else going on here. There's no rhyme or reason why that patient is having a neurosensory impairment on this one, because
So
there's
it almost seems like an autoimmune reaction to the implant because it's well,
well,
again, it's only in the
it's not going to be an autoimmune because
no.
it's localized. If you had any localized reaction to the implant, is the tissue bleeding? Is it inflamed?
No,
Is
the
it?
tissue's perfectly healthy looking. Like
Yeah.
clinically, everything looks great. It wasn't until so it was 5 days after we took the CBCT, and then we saw the darkening that was occurring on this one, and it was only evident, on the CBCT. Nothing was noted clinically.
Okay. Well, if the patient's in pain, I would take it out. Um, the good news is you can just do a conventional fixed partial denture. I would probably say there's too many questions here to go in on a third time.
Okay.
I have a feeling I would probably just inform the patient that they may have an underlying trigeminal neuralgia, maybe just a subclinical case of it, because again, for the maxillary branch to become symptomatic, that's very, very abnormal.
And
So
that's happening again this time. And
yeah,
my thought was maybe it's anxiety, fear over everything because she's a very anxious person, and with the
yeah.
tension in the jaw, it's putting pressure on that nerve.
And,
I gave her the
and
option of doing 3-unit bridge, or I was going to. We have Kevin Suzuki that's just down
yeah,
in Seattle from us, so I was gonna that as a secondary option of going down and having him look over the case to see if there's
Well,
something.
I can guarantee you that Kevin, if he would see this 2 times, same neurologic issues, uh, it, it's an implant, not a big deal. Do a 3-unit bridge, but
Okay.
you can still consult with him. But he's pretty cautious on that, and there's just this is too strange. Very, I think she has an underlying neuralgia there. So
Okay. Would that cause the inflammatory response, the
yeah,
neuralgia?
because it's a trigger. So the surgery acts as a trigger.
Okay.
Yeah. And I've seen it before, not very common, but remember that's an inert implant. It's titanium biocompatible. You're not having a localized reaction because you're not having severe bleeding or tissue inflammation. You're just having localized pain. And where's the pain coming from? Think about it. There's no nerves to that.
Okay.
All right. So the
Yeah.
inferior alveolar's in the actual canal.
Okay.
Yeah. Okay.
All righty. Yeah. Thank
Okay.
you for looking
Let
over
me know
that.
how that works out.
Okay.
Okay. Take care, Doc.
Bye.
Okay. Hussein, who do we have on deck?
Dr. Washington is next, Professor.
Okay.
Do-
Cole, how you doing, buddy? Is Cole on?
Dr. Washington, would you mind unmuting yourself? Yes, he's on the list, sir.
Hello.
Let me ask him to unmute, Professor.
Sorry, I was trying to. I was starting to struggle with the mute button.
Okay. I thought you were on vacation again. Weren't you going on
No,
vacation
sir.
last time you were
Yes,
on?
sir. We're in the Keys, but it's getting a little.
That's right. See, I have a good
up.
memory.
Yeah.
Yeah. Okay, Doc. So what do we have?
We have a 21-year-old female. She's actually the stepdaughter to the partner in the practice, and
Okay.
she has a congenitally missing number 10
Okay.
with not a lot of bone and an awkward restorative space. And actually,
Okay.
it's 10 and 11.
10 and 11. Okay. So right off the bat, that space looks very, very small. So let's did you take some measurements on this, Hussein?
Yes, sir. I did add 2 virtual crowns, Dr. Resnik, just to represent or try to mimic the size of
Yeah.
number 10
Let
and
me just
11.
look
And
straight on aesthetically what that's. Okay. Okay.
they're pretty
Does
small,
she have a
sir.
high smile line, Doc?
Not really. You can barely see where the gums and the tooth meet, but overall, when she smiles, you really don't see where the gums and the tooth meet.
Okay. So one thing that you can do, Doc, is you can do an enamelplasty on the mesial of that first bite. And I think you can probably get a little bit more of a lifelike canine there. Okay. So you can just do a little enamelplasty right there and
Yeah.
then make that a little bit wider. Okay.
What would your thoughts be about a potential
Cantilever?
Yeah.
Yeah.
Or even
Well, I don't think you're going to cantilever this one. So let's see. First of all, did you offer any ortho to the patient by chance?
I mean, she is the stepdaughter, so she can get kind of whatever she wants.
Okay.
So if
I
ortho's the right
would
option.
I would just give that as an option, orthodontics. So you could open that space a little bit, just with some orthodontics. How old's the patient?
She is 21.
21. So, I mean, that might be an option, just opening, that space a little bit more. It'll be just a little bit more aesthetic, I think. The problem that you have, Doc, is you have the right side, which are rather normal size, lateral and canine, and then you have these micro ones on the left, which I think if you close some of those spaces, you could probably gain that back. But I would give that as one option. Let's say that is not a viable option. So Hussein, can you give me a axial view? Let's see how much space we have here, Doc.
You got it, sir.
So what he's going to do, Cole, is he's going to give us an axial measurement. So what do you have there? 11? Okay.
11.0, sir.
Okay. So how about for the clinical crown? Do you have a measurement for that?
Here we go.
Okay. He's going to measure this. Let's just see what the crown is.
It's 7.0, sir.
7.0. So Cole, if you remember, a lateral incisor is 2/3 the size of a central. A central is 9 millimeters mesial distally. So a lateral should be 6. And then a canine should be 8 to 9. So right off the bat, you're not even close to getting 2 teeth in there, let alone 2 implants of normal average size. So what did you do here, Hussein? How did you work this up?
So I attempted on adding an implant at the embrasure area in between the sides of tooth number 10 and
I
number
love it.
11.
Perfect, Cole. He
And
did it. I was
here's
quizzing him. I was going to see if he did it. I love it. Okay. So you don't want to do a cantilever, Cole, because if you do a cantilever, what ends up happening? Show us the 3D image with the implant in.
sir.
So Cole, remember how we treat lower anterior implants? You know, we put them in one implant in the brazier for 2. You're going to do the same here.
That's what I was going to ask. I didn't know if it would work at the top.
Yeah.
It would still look good.
This is rather uncommon. No, it'll look perfect because you're going to be lingual. So it'll be coming through the lingual. This will be perfect. However, you're going to have to do a bone graft. So let's go back to the cross section. Let's just move that implant out of there. So we could just see the bone. Okay. Cole, remember what type of defect this is?
Yeah, it's the catcher's mitt, right?
Catcher's mitt. This is a catcher's mitt. Easiest one to do. So I think 2 little tent screws there. I think you'll be able to build this up real nice. Graft it first, and then go ahead and place the implant. So this is what I would do, Cole. Let's go back to the 3D model. This is one of the doctors in your office stepdaughter.
Yes, sir. This is my partner's stepdaughter.
Okay. Do you do Invisalign?
I do some cases, but he does the majority of the cases. So
okay, then let him do it. Okay. Here's what I want you to do. I want you to graft it. While the graft is healing, have him separate these teeth a little bit. You'll be able to get, I would say, 1 millimeter on each side. So it'll look a lot better. You'll still not be able to put 2 implants in. There's no way that will happen, but it will just open it up enough to where it'll be a lot more aesthetic. Okay.
Okay. One thing, one of the big issues that I've had with these GBRs like this is getting enough of a release to get a tension-free closure.
Yeah.
How far would you extend the vertical release?
Let's look at it from the buckle, the 3D.
Yes, sir.
Okay. So, Hussein, can you draw a line, papilla sparing? I want you to go straight up on the central, distal, the central. No, I want to show him the incision. So we're going to leave the sulcular tissue. No, let's go right up, right from here, go straight vertically up. Okay. Now move that over so it's more towards the tooth. Move the whole thing over.
Here we go, Professor.
And then on the other side, go up to the mucogingival junction. Okay, do it on right there. Keep going, keep going. Now go 45-degree lateral. No, opposite.
Oh, sorry.
Distal.
Sorry.
Okay, there you go.
Here we go.
Now do another one on the other side. Yeah. So Cole, what you want to do, go up to mucogingival junction, 45 it, and really extend that release, and you'll be able to bring all that tissue over, no problem. Easy, simple.
Okay. Well,
okay.
Thank you very much.
Before you do it, just text me or email me. I'll walk you through it. Okay.
Yeah. The only concern, and I don't know if it's something that I should stop doing, but she is 21, lives in Miami, smokes a lot of weed and drinks a lot. And I guess it's concern trying to build that much bone on her.
Okay, 21, lives in Miami and smokes a lot of weed. Is that what you
Smokes a lot
said?
of weed and drinks a lot.
She drinks a lot too. Okay.
Yeah.
So you're
So,
going to educate your associate on what happens with marijuana and with alcohol. So
okay.
go on the Gladwell website. I wrote an article in the last journal on marijuana, and about a year ago, I wrote one on alcohol. Have them read both of those.
Okay. Yes, sir.
Okay.
Thank you very much.
Okay. She needs locked in her bedroom.
Yeah.
Okay. There you go. Okay, Cole. Take care.
Yes, sir. Bye.
Okay, who's next?
Dr. Lee, Dr. Tram Lee is our next doctor, professor.
Hi,
Dr.
Dom.
Lee.
How are you?
Hi, how are you?
I'm good. I'm good.
Good. So, Doc, he's going to put up your second case. Your
Yeah.
first one, on a scale of 1 to 10, is about a 30. So, difficulty. So, I'm going to talk to you independently on that.
Yes.
We could actually do it for the whole grand rounds, just talk about that case. But he's going to send that case to me tonight. I'll get back to you within the day or so. Okay.
Yes. Thank you.
Okay. So what do we have on your second case here?
We have a young female, I think in her 20s or early 30s, very healthy.
Okay.
No medication, no allergies. She came to the practice last year because number 30 was endo treated and it had a huge infection and
Okay.
a tooth I think the distal root was also resolving at the time.
Okay.
So my boss extracted the tooth and did the graft.
Okay.
And now she came back and she's from Australia, and at first she wanted to go back there to get it done, but now she lives here, so
Okay.
she's ready to go. So yeah, so this is her scan.
Okay. So let's take a look. What you work this up, Hussein?
Yes, sir. I do have a 5 by 10 millimeter long implant at the site of number 30, Professor. Perfectly clear away from where the mandibular canal is. Good bone coverage to the lingual and to the facial. And I'm going to start scrolling around that implant for you, sir.
Okay. Okay. So, Doc, on this one, the good news is you have a type 3 nerve. So look how low the nerve is. On the facial there, you have a radiolucency there. Do you know what
Yeah.
type of bone he used?
No, it's a cortical canticulus. Yeah.
Okay. So how long ago was it the graft? Do you know?
Exactly a year ago.
Oh, wow. Okay. So that bone never turned over. So you're going to be placing the implant, Doc?
Yeah, I want to.
Okay. So where he has it, do you see where he positioned the implant? It's going right into the lingual cusp of the maxilla. So this position is perfect. If you place the implant in this position, what I want you to do is you're going to make a little envelope flap, just extend it a little bit more onto the buccal and see if you have a little bit of a defect there. What I'm thinking, Doc, is that bone never turned over and you have some soft tissue there. So what I would do is first place the implant and then go ahead and if it is soft tissue, curette that out, bone graft it, put a small little membrane over it, and then close it up. Okay. Now, sometimes you get fooled and it is bone, but it's real soft bone. This could go either way. It just looks to be a little bit of a area of osteoid, which is kind of not even woven bone. It's usually very, very soft. Okay. But if it's been a year, it probably has not turned over. Will it turn over? So put the implant in. If you have to debride that area, you can even decorticate. Hussein, can you show her how to decorticate into that buccal bone, like mid-implant on the facial? Right. Yeah, right in there. just decorticate that area and go ahead and graft it, and I think you'll be fine.
Okay, and just graft it and put a membrane over
Yeah, so
the
put
implant.
it, yeah, so just graft it because it will be a wall defect.
Yeah.
So it'll be like a catcher's mitt. Graft it, just put a small piece of collagen, regular collagen, just like
Mhm.
that. Okay. And then just close it up. You're good.
Is it better to like just do kind of like open it up and graft it?
I don't think I would do your osteotomy. The only way I would abort the surgery is if the bone is so soft when you start to drill into it. I think the rest of the bone will be all right,
Mm-hmm.
but that would be the worst scenario that you would have to regraft it.
Okay.
I don't think that will happen, but always be prepared. You know,
So would it be safer to do a guided for this one?
yes,
Yeah,
at least I would just do a pilot guide, Doc.
yeah.
You remember a pilot guide. So just do a
Yes.
pilot guide. It will give you the trajectory, the depth, mesial, distal, buccal, lingual, and the depth, and then do it freehand from there. You're good.
Okay.
Okay.
Yeah. Thank you.
Okay. Take care. Okay. Uh-huh. Okay,
Next,
Hussein, who do we
Professor.
have next?
Dr. Gupta is next, sir.
Dr. Gupta, how are you?
I'm doing very well. How are you, sir?
Okay. Now, I think last time you were flying somewhere, right?
Uh, no.
No?
Yeah. Oh,
Okay.
long time back. Yeah, long time
Yeah,
back.
two grand rounds ago.
Yes.
Okay.
Yeah, two
Because
grand.
you pulled over on your way to the airport. I
Yes,
remember that.
yes.
Okay, so tell us what you have for us.
So, 59-year-old female with no significant medical history, just taking regular multivitamins and on hormone replacement therapy. She
Okay.
is not interested in doing endo in number 3. It's been intermittently symptomatic, so we are planning to extract it and eventually do implant a replacement.
Okay. Okay. So if we look at that, we have a cloudy sinus. So
Mhm.
we have an infected sinus or an inflamed sinus. We have a communication where he just put that arrow. So that's a communication on the lingual root into the sinus proper, causing a rhinosinusitis.
Mhm.
So you weren't thinking of doing this immediate, right?
No, no.
Okay. So, Doc, here's the issue that we have here. You're going to take this out. You're most likely going to enter into that sinus on both the buccal and on the lingual. What I would do is curette it out as best you can, just the socket. Don't go in the up, don't go into the sinus proper. Just curette the socket and then get a collagen plug, put some Ancef on it, and then pack the collagen plug in and just close it up.
Okay.
You don't want to graft. If you try to graft, number one, the infected bacteria or the bad bacteria from the sinus is going to drain into this area and it's going to be problematic. Your graft will probably never heal. So what usually happens in these, Doc, is once you take out the tooth, that sinus should clear up. So it's almost like if you get a splinter under your in your finger, it doesn't heal until you take the splinter out. We're taking the tooth out to clear up the sinus. I would wait about 2 to 3 months, take another scan, verify the sinus is clear or is a lot better, and then go ahead and work it up to see how much bone you have.
Sure.
Okay. Now, what I would do on this patient 1 day prior to doing this procedure, put them on Augmentin 875, 125 BID for 10 days. Okay. The reason is that this patient, you don't want to take this out and stir up all this bacteria and they end up with a bad symptomatic in a sinus infection. So treat them with Augmentin.
Oh, okay.
Okay.
And any pointers on extracting it so I don't end messing up end up messing up the buccal and lingual palatal walls?
To be honest, Doc, it's inevitable. There is no lingual plate, and the buckle is going to be, you're not going to have much left on this.
Yes, doc.
Yeah, unfortunately. That's what happens when you have those roots that are diverging like that.
Okay. So is it better like just to talk to the patient and educate it to rather doing endo in such cases because implant it's or just let it be?
Well, the problem is, I think if you did an endo here, it would
Uh-huh.
never heal anyway,
Yes.
because you have what is called a rhinosinusitis. It's probably a chronic rhinosinusitis and also an odontogenic infection. And
Sure.
it's a combination, so it's a mix. So you have the bad bacteria from the sinus, you have the bad bacteria from the oral cavity. So it's a double whammy. It's not good. So even if you did an endo on it, it probably wouldn't be,
Probably won't be.
the tooth needs to be taken out. You'll be surprised, Doc. Take the tooth out, just let it heal. You're going to have to do a little bit of, you're going to probably have to do a SA3 sinus graft,
Uh-huh.
but you would have to do that anyway, because, I mean, measure the amount of bone you have there, Hussein,
Yeah.
from the sinus to the furcation.
Right now, Professor, we've got
Yeah.
exactly 4 millimeters.
Yeah, you have 4 millimeters of bone. So
Yes, sir.
once the tooth comes out, it will remodel. You'll probably have probably 5, maybe a little bit more after that. So I think you'll be all right. You just where people make a mistake is they graft these cases. You see the communication. Remember, 42% of the time the roots of the molar will be in the actual sinus proper.
Sure, doc.
Yeah.
All right. Thank you so much, doc.
Okay, Doc, didn't you get the 94 on the exam last time?
Yes.
See, I have a good memory.
You do.
Okay. Okay. Take care. Have a good night.
You too. Thank you.
Okay. Next case.
Professor, next case is for Dr. Cassandra Murphy. Dr. Murphy, would you mind unmuting yourself and presenting your case to Dr. Resnick, please?
Hi, Doc. How are you?
Doing well. How are you, Dr. Resnick?
Good, good. What do you have for us tonight?
I have Karen, who is 65.
Okay.
Health history wise, she is on Armor Thyroid, and that is it.
Okay.
So
okay.
she had I thought we got a lower scan on her, but I don't know, I couldn't find it.
Okay.
So she has been told before she doesn't have enough bone for implants at all, ever.
Okay. Okay.
Yeah, go.
Okay.
That's mainly it. Go ahead.
Okay. So were you planning on doing a full arch on this?
Well, at this point, I want to know your opinion because
Okay.
she's not ready to jump into it right now. So that gave me some relief.
Okay. So why don't we do this? Let's do a cross section from molar to molar.
Yes, sir.
And Dr. Hussein will blow it up and let's see what we have here. So he's going to scroll from number 3 over.
So pretty much at the right quadrant, Dr. Resnick, where we've got the right maxillary sinus, the native bone is approximately 3.3 millimeters over here, sir. As I keep on scrolling anteriorly, the height of bone above the sinus isn't that great. Then we're gonna reach tooth number 6, where there is a crown which is not fully adapted to the lingual finish line over here. Then we've got the ponic, where that's tooth number 7. The buccal lingual thickness of bone over here is not adequate. Then we're going to scroll to tooth number 8. That's tooth number 9, Professor.
Okay. And there might be some decay on that too. Okay. Keep going.
And here is the left maxillary sinus, sir. The bone quality over here seems to be very soft, Dr. Resnick.
Yeah.
The height of the ridge is approximately 7.0 millimeters over here, sir. We've got better height at the left side, Dr. Resnick, in comparison to the right side, Professor.
Okay. So, Doc, here's what I would say on this case. I would not build up implants on the right and on the left and maintain those teeth. The reason is those teeth, that number 6 could be very lost very soon. You have some significant decay in there. There's not going to be much left of that. And what do you do with 4 teeth? They kind of get in the way, if anything, from with aesthetics and function. So I would educate this patient that anything short of, I would not even think of grafting on both sides and then placing implants and keeping those teeth. I think it prosthetically that would be a complete nightmare and would be very difficult to complete. So I would look at taking these teeth out. I would start to educate the patient that they're going to lose those teeth and it's going to then be a full arch case where you could do removable or fixed, but you're going to have to do sinus grafting. Okay.
Sure. Yeah, yeah, that's what we've talked of, like down the road, whether that's a
Yeah.
year, a few
And,
years. She
yeah.
realizes she'll lose all of them, but I didn't know like how do you phase that out so that if we're grafting and we're extracting at likely the same time, how are we going to have her have any removable thing without touching any of those areas? Do
Yeah.
you phase
So,
that out?
so she's going to need the treatment is basically going to be she's going to have these teeth taken out, and then you're going to graft the canine areas, possibly a little bit in the anterior, and then the sinuses. Uh, and then she would just get a upper conventional denture with a good palatal coverage. And anywhere where it's grafted, you would hollow that out. So there would be no pressure on the area. So go ahead, take that out, take the teeth out, Dr.
Yes, sir.
Hussein. Okay. So we would strategically come up with the positions that you need to graft. You don't have to graft everything. We just need specific areas that need to graft. Bilateral molar areas, bilateral cuspid areas. Okay. How
Okay.
old's the patient?
65. How
65.
how many implants do you think we'd be able to get in there doing it that way?
6 implants.
Oh, okay. You think
Yeah. So I would probably say on this case, canines, bilateral, second bis, and first molars. And that would limit your
okay.
grafting. So even though it sounds like a lot of grafting, it really isn't.
Wouldn't really be that much.
Yeah. But
Okay.
you can't save the teeth and
Sure.
graft. Okay.
Yeah. Oh no,
That won't work.
she's fully aware she's gonna lose all of them.
Yeah. And so to answer your question, as long as you keep the primary stress-bearing area, which is the horizontal palate, you can remove the flange on those 4 areas that we're going to graft, and it doesn't even have to touch them. So you would make the prosthesis that it would never be able to touch where the implants are.
Okay.
Does that make sense?
Yeah, no, completely.
Yeah.
I haven't had experience with cutting out portions of relief on a conventional denture. How good do patients typically do with that in that interim phase?
They do fine because you can use the palate. You can even use adhesive right in the
Okay.
center of the palate, and it holds it in. So they get used to it basically. You'll
Okay.
not have a complete suction, but for the bone grafts, the majority of the bone graft is going to be vertically anyway, in both sinuses.
Right.
The canine, I think you're going to be fine on the right. On the left is going to be a little bit more challenging, but it's only 4 areas. And when you get to that point, I'll walk you through exactly how to remove that.
Okay.
Okay.
Perfect. Thanks so
But
much.
this one is all about educating the patient
Yeah.
and their current position. Okay.
Yeah, great. Thank you.
Okay. Take care. Have a good night.
You too.
Okay. Okay. Who do we have, Dr. Hussein?
Dr. Maria Benefold is our next doctor.
Dr. Maria, how are you?
I'm wonderful. How are you?
Good, good. What's going on? What do you
Wonderful.
have for us tonight?
So this patient I saw on Monday or Tuesday, I sent her to endo and they discovered she does have a root fracture, so for a retreatment. So I wanted to see if this would be a good candidate for an immediate placement. I
Okay.
planned out a 5 by 10. So either, if she's fine with, I did explain to her due to the infection, most likely it would be a bone graft, healing, and then come back. But I thought, let me present it and see what
Yeah.
you think.
So just for everyone else on the call, when we look at molar immediate implants, we look at 2 to 4 millimeters beyond the apex that we need.
Yeah,
So
we can't do
remember,
that.
there's a type 1, type 2, type 3 nerve. This is a type
Yes.
2 nerve.
Yeah,
So you could do it in a type 3 nerve, but not in a type
not
2.
here. Okay.
Secondly, see that infection there on the buccal?
Yes.
That infection's pretty significant, that
Okay.
when you take this out, there's not going to be anything left. So what I would do on this one, Maria, again, you'll never be questioned by telling a patient they have to heal and you have to do it the conservative way. Trying
Yes.
to do a heroics on a case like this would, I give it about a 20% chance of working. So, and
Okay.
you might end
Okay.
up with a nerve impairment. So, with that being said, I would say phase 1, take the tooth out,
Okay.
debride that whole area, decorticate into the lingual. See all that good bone there?
Yes.
Get it? You have plenty of bone from where these roots are to where the nerve is. So,
Mm-hmm.
you'll be able to debride it real well. Graft it, come back and put an implant in really good, solid bone. You get to
Okay.
sleep at night. The patient
Yes.
doesn't have to be, their treatment doesn't have to be extended by a half a year, and it just makes a lot of sense.
And that
Okay.
is what I told her, but I thought, well, let me
Yeah.
just present it and
So
see what your
so for
thoughts
everyone
are.
else on the call, we want 2 to 4 millimeters beyond the apex. However, as you see, Dr. Hussein put 2.2 there. That is
Mm-hmm.
to the actual nerve. We need 2 millimeters to the zone of safety.
Yeah.
So we actually have 0 because by the time you'd extend it, you'd be right into the nerve. So you
Okay.
actually need at least 4 millimeters from the nerve to the apices to do an immediate. So this would not be a good one. Okay.
Okay.
So, but you got this one down, Pat. You do a ton of these now, right?
That's right.
Good. I love it. Keep it up. Okay.
Thank you.
Any questions?
No, this is
That
great.
makes
So
sense?
the saying you looked at a 5 by 10. I mean, because I play around with the software and just future. I know
Yes,
once we heal, then we'll decide.
Yeah, you
I had a 5 by 10, doc.
yeah, Marie, you're almost likely to have a 5'10". Possibly the worst scenario would be a 5'8", but I think you'll get a 5'10" in there, no problem.
After
Yeah,
healing.
after healing.
Wonderful.
Yeah, because he even gave you a little bit of buffer there apically. So yeah, you're good.
Wonderful.
Yeah.
Wonderful. Thank
Okay.
you.
Okay. Have a good night.
You too.
Okay. And who do we have next?
Last case is for Dr. Daniel Winter, but I don't think I could find Dr. Winter onto the participants list. I might be mistaken, Dr. Resnik. Dr. Winter,
Okay.
if you're
Dr.
here,
Winter, are you on? Okay. How about Dr. DiBartola? Do we have Dr. DiBartola
um,
on?
I don't think so, sir.
Okay. Okay. Well, let's see. It is 8:08, so that was great. We'll get the rest next time. For everyone on, we had a lot of people we had to turn away tonight, so get your cases in early. And thank you for putting the cases in. I see Rick was busy there, so thank Rick. And again, Dr. Hussein, he does a great job with this. Thank you very much. And
Thank you,
we'll see
Professor.
everyone in November. Okay? Everyone
Looking
have a good
forward to
night.
it, sir.
Thank you.
Thank you, sir. You as well.